Welcome to the Peripheral Artery Disease Vodcast titled First Steps, Empowering PAD Management Through Lifestyle Change. Quitting smoking is the single most effective lifestyle change to slow the progression of peripheral artery disease, PAD. And it can even improve walking distance and reduce leg pain. In this episode of the PAD Vodcast Series, experts share practical, evidence-based strategies for managing PAD, including smoking cessation, supervised exercise therapy, nutrition, and pharmacological approaches. Featuring expert insights and real patient stories, this vodcast empowers healthcare professionals to support vascular health, improve mobility, and elevate quality of life. This is part of the PAD National Action Plan. Motivating patients toward lifestyle change. Behavior change is hard. Behavior change is defined as the ability of an individual to recognize the need for health behavior change and possess the motivation to make the change. Healthcare providers often tell patients what to do or educate patients and think that change will occur. But knowledge alone does not change behavior. Behavior change is best accomplished with a multiple-faceted approach with the healthcare provider as a partner in motivating the patient, setting goals, and developing realistic treatment plans. This multiple-faceted approach should focus on the patient's social determinants of health. Social determinants of health include education access and quality, healthcare access and quality, economic stability, neighborhood and built environment, and social and community context. Motivational interviewing and coaching are two important communication techniques that healthcare professionals can use to motivate patients to set goals and change behavior. Motivational interviewing, rooted in social learning theory, is defined as a collaborative, goal-oriented style of personal motivation with a particular attention to the language of change. It is designed to strengthen personal motivation and commitment to a specific lifestyle change goal by exploring reasons for change and past experience with change. Motivational interviewing aims to resolve ambivalence and alleviate resistance towards making a health behavior change. Begin a motivational interviewing conversation by setting an agenda. Then ask open-ended questions to allow the patient to tell their story. Affirm and reinforce that there is understanding by the healthcare provided by reflecting on what is being said. Summarize the conversation every 5 to 10 minutes to capture all the important dialogue. To motivate the patient, use these 4 steps during the motivational interviewing session. First, deal with ambivalence, reasons not to change, by asking the patient to determine the good things, challenges, and consequences of changing. Secondly, deal with resistance. I don't want to change, by asking the patient to determine the best and worst things that could happen if change occurred. Third, build motivations for change by asking the patient to articulate problem with changing and verbalize concerns. Fourth, determine readiness listening for I can change language. Then measure readiness by asking, 1. On a scale of 1 to 10, with 10 being very important, how important is it to make this change? And 2. On a scale of 1 to 10, with 10 being very confident, how confident are you that you can make a change? Confidence and importance numbers of 7 or greater indicate readiness to change. Once readiness is determined, work with the patient to develop SMART goals: specific, measurable, action-oriented, realistic, and timed for being met, and follow-up plan for success. Evidence-based interventions like incentives, rewards, tracking logs, just-in-time text reminders, relapse prevention plans, support accountability partner, and others should be discussed with the patient. Health coaching is also effective in promoting health behavior change. Health coaching is defined as the practice of health education and health promotion within a coaching context to enhance the well-being of individuals and facilitate the achievement of their health-related goals. The steps of health coaching include 1. Precisely defining the behavior to be changed, setting realistic goals and reward achievements. 2. Build positive and accurate expectations about results over time. 3. Include self-monitoring, plans for relapse, feedback, and reinforcement. Use prompts and cues to remind the individual about the desired behavior. And 4. Teach problem-solving skills if an individual needs them. Assessing the ability to problem solve is important in health coaching as the goals and plan are being developed. In summary, behavior change is complex and needs a multifaceted approach that includes a solid relationship with a healthcare professional that will partner with the patient to set goals, develop a realistic treatment plan, and provide follow-up to ensure success. Choosing the right shoes and socks for exercise content. The foot consists of 26 bones, 33 joints, muscles, tendons, and ligaments, all playing a role in shock absorption and propulsion during walking and running. During walking, the foot absorbs about 1.5 times a person's body weight with each step compared to 3 times the body weight with each step of running. When walking, the rolling action from heel strike to toe off requires soft, flexible soles to aid in push-off from the big toe with each step. Also, walking shoes have an angled heel to absorb most of the shock heel strike to reduce pressure on the ankles. In contrast, runners' feet strike the ground anywhere from heel to the midfoot or forefoot. Therefore, running shoes have thicker soles for shock absorption and are lighter in weight. Due to these differences, one can wear running shoes for walking, but one should not run in walking shoes. These repetitive pressure and shear on the foot from improper fitting shoes and socks can result in blisters and calluses that leads to pre-ulcerative lesions. Due to different foot shapes and sizes, it is impossible to recommend a specific running shoe or walking shoe that suits everyone. Individual professional advice on shoes with proper support and shock absorption is recommended to reduce the risk for injury. The heel counter gives support to the heel, and it can be soft or rigid and helps control heel motion. The midsole provides cushioning. The sole provides protection and controls the friction to the ground. The heel flare standard angle is 15 degrees. The greater the heel flare, the greater the stability. Here are some basic guidelines for shoe shopping. 1. Visit a specialty running store for a variety of styles and expert hands-on fitting. 2. Arch and gait evaluation to assess if one is a pronator, supinator, or stays neutral. 3. Shop for shoes in the evening as the feet are largest at this time. 4. Bring socks, orthotics, or special inserts to ensure proper fit when trying on the shoes. 5. Foot size changes over time. Have a professional measure both feet for length and width. 6. There should be a ½ inch between the longest toe and the front of the shoe. 7. The shoe should bend easily at the ball of the foot. 8. Shoes should be replaced every 300 to 500 miles. 9. Minimalist shoes are not suitable for people with peripheral artery disease or diabetic neuropathy. Risk factors leading to blister development include dampness, sweat, temperature, and friction. Choose non-tight, seamless socks that wick moisture away from the skin. Wearing socks decrease the friction against the skin and shoe. Wool socks are associated with improved skin health by reduced transepidermal water loss and increased stratum corneum hydration compared to acrylic or cotton socks. Furthermore, when the new and used sock fabrics were subjected to repeated compression cycles, recovery from compression and the absorption of energy were lower with the used sock. Wearing 2 pairs of socks during physical activities also diminished friction against the foot, thereby reducing blisters and skin irritation. Note that wearing 2 pairs of socks may reduce friction in some cases, but can also lead to excess heat and compression. Applying antiperspirants to the feet to reduce sweat has been shown to be effective at decreasing foot blisters, subungual hematomas, wounds, sprains, muscle problems, and chafing. 5. After exercise, patients should inspect their feet for visual checks for blisters, cuts, redness, swelling, or any unusual changes in skin color or texture. Palpation for any areas of tenderness, warmth, or lumps that were not present before. Assess for any numbness or tingling sensations which could indicate nerve issues. Look for ingrown toenails or fungal infections, and ensure the skin is moisturized to prevent cracking. If any problem arises, patient referral to a podiatrist for evaluation will minimize potential complications. Choosing the right shoes for exercise for at-risk foot should involve professional guidance based on the foot shape and the activity involved to prevent unnecessary injury to the foot, ankle, and leg. It is best to buy shoes in the late afternoon or evening when feet are most swollen. Both feet should be measured for length and width. Bring socks and orthotics to the shoe fitting. Wear socks without seams and avoid tight socks during activity to avoid irritation to the skin. Choose socks that wick moisture away from the skin to maintain skin health. Replace old shoes and socks to maintain shock absorption during activity. After each exercise session, check the feet for unusual changes. Nutrition and hydration in PAD. Peripheral Artery Disease, PAD, is a cardiovascular disease that often results from chronic inflammatory effects on arterial vasculature. This chronic condition is often associated with many risk factors that are present because of poor nutritional habits. Because PAD goes undiagnosed in many, including Black Americans, Hispanics, and Native Americans, focusing efforts on primary and early secondary risk reduction is vitally important. There is some evidence that imbalanced nutrient intake may contribute to the development and progression of PAD. By promoting better nutrition, oxidative stress may be reduced and physiological mechanisms such as enhancing endothelial cell function, improvement of erythrocytes, blood viscosity, and oxygen perfusion may reduce muscle ischemia. A heart-healthy lifestyle includes good nutrition and plenty of fluids to maintain these physiological mechanisms. Nutrition that focuses on the intake of anti-inflammatory and antioxidant-rich foods has been shown to improve functional impairment and ischemic outcomes in individuals with PAD. Research conducted with PAD participants has shown the presence of high saturated fats, sodium, and cholesterol. In addition, foods low in fiber, vitamin E, and folate were identified. This is largely due to consuming high-fat, high-sodium diets with little vegetable and fruit intake. Therefore, the focus for nutrition education should be on low-fat, low-sodium diets rich in vegetables, fish, fruits, legumes, and nuts. Considering that many in the PAD population are from health-disparate populations with reduced social determinants of health encouraging a heart-healthy diet may not be realistic. Those with health disparities often have lack of financial means to buy food or food supplements, are living in food deserts where water isn't always drinkable, and there are also cultural considerations about food preferences. A healthy lifestyle plan that can serve as a good foundation for dietary change is what healthcare professionals should recommend to their patients with PAD. This should include a referral to a nutritional expert or diabetes educator who can evaluate the patient's social determinants of health and cultural and personal preferences and develop a plan in collaboration with the patient. Recommendations should include eating fresh or frozen food without added sugars or sodium, a variety of vegetables, fruits, whole grains, soluble fibers and legumes, and fatty oil fish like tuna and salmon. Use olive oil and canola oils to minimize saturated fats. Key diet plans that map out menus are the DASH diet and Mediterranean diets. In conclusion, nutrition and hydration should be included in all treatment plans for patients with PAD to modify eating habits, lose weight, and promote optimal well-being. Medications for peripheral artery disease. Another crucial topic we incorporate into lifestyle in the pharmacologic management of peripheral artery disease, or PAD. PAD significantly impacts patient quality of life and is a marker for systemic atherosclerosis. Our primary goals with medication are to alleviate symptoms, improve functional capacity, and reduce cardiovascular morbidity and mortality. For symptomatic PAD, particularly claudication, cilostazol is often our first-line agent. It's a phosphodiesterase inhibitor that improves walking distance by increasing blood flow and has antiplatelet effects. Although cilostazol has antiplatelet effects, it is not a substitute for standard antiplatelet therapy. Contraindictions, especially heart failure, must be rigorously screened for. Beyond symptom management, aggressive risk factor modification is paramount. Statins are critical for dyslipidemia, significantly reducing cardiovascular events. Consider high-intensity statin therapy unless contraindicted. Antiplatelet therapy is foundational. For patients with symptomatic PAD or those who have undergone revascularization, clopidogrel may be preferred or considered in addition to aspirin in specific high-risk scenarios. Though dual antiplatelet therapy for PAD solely on medical management is less common outside of acute coronary syndromes or recent revascularization. Finally, early diagnosis and optimized management of comorbidities that contribute to chronic low-grade vascular inflammation, diseases like hypertension and diabetes, is our ultimate goal. Controlling for modifiable peripheral artery disease risk factors can limit the progression and prevent onset of symptomatic PAD. Optimal blood pressure control with agents like ACE inhibitors or ARBs and strict glycemic control contribute significantly to overall cardiovascular health and slow PAD progression. Chronic conditions monitoring. The American Heart Association states that PAD is estimated to affect 10 to 12 million individuals in the United States who are greater than 40 years of age, especially those with diabetes, high cholesterol, or a history of smoking. One key symptom is claudication, leg pain during walking that subsides with rest, or rest pain relieved by dangling legs on the side of the bed during sleep. Other symptoms include slow-growing nails, shiny skin, tingling and/or numbness in the legs and feet, thick toenails, changes in skin color, slow-healing sores. PAD is a common manifestation of systemic atherosclerosis, and diabetes mellitus remains one of its strongest independent risk factors. Hyperglycemia drives endothelial dysfunction, promotes oxidative stress, and impairs nitric oxide availability, all of which accelerate atherogenesis. Studies have shown that patients with diabetes have a 2 to 4-fold increased risk of developing PAD compared to non-diabetic individuals. More importantly, glycemic variability and postprandial hyperglycemia have been linked to inflammatory cascades that exacerbate plaque instability and microvascular compromise. In a cohort study published in Atherosclerosis, elevated glucose variability was associated with greater intima media thickness and arterial stiffness. Although the gold standard is still the HbA1c in monitoring the blood sugar management of a patient, the use of continuous glucose monitor, CGM, provides data missed by HbA1c. It shows blood sugar trends missed by both fingersticks and HbA1c. Here is a graph of HbA1c and the average blood sugar level for the past 90 days. This is where real-time glucose monitoring, especially via CGM, plays a transformative role. CGM enables earlier identification of deleterious glycemic trends, which can inform anti-hyperglycemic therapy adjustments and lifestyle counseling. The alarms provided by the CGM alleviates hypoglycemia fears. In addition, it becomes a strong behavioral modification tool as patients see how food, exercise, stress, and more affects blood sugar. Moreover, best glucose control is correlated with improved wound healing and reduced rates of lower extremity amputation, key outcomes in PAD care. For those without CGMs, patients should be encouraged to check their blood sugar via fingerstick a few times per day and aim for blood sugar less than 180 milligrams per deciliter 2 hours after eating per American Diabetes Association guidelines. Anytime the patient has nightmares, cold sweats, shakiness, blurred vision, or vivid dreams, a patient should be instructed to check their blood sugar for hypoglycemia and follow the 15-15 rule for low blood sugar management. Integrating glucose monitoring into PAD management is not just about diabetes control. It is about vascular preservation, limb salvage, and cardiovascular risk reduction of heart attack and stroke. Smoking cessation. Smoking comprises one of the most prevalent and modifiable risk factors for peripheral artery disease, PAD. Smoking cessation is one of the most important steps in preventing progression of the disease as well as reducing overall cardiovascular risk, including heart attack and stroke. In addition, ongoing smoking threatens the durability of revascularization therapies such as endovascular intervention and surgical bypass grafting. While smoking cessation is a Class 1 recommendation for treatment of PAD, according to the 2024 AHA-ACC guidelines, smoking cessation aids and counseling are underutilized. The AHA-ACC PAD guidelines recommend a discussion of smoking cessation as every visit in patients with PAD who still smoke. Similarly, other forms of tobacco use should be discouraged. The 5A framework, ask, assess, advise, assist, arrange, has been proposed as an effective starting point for effective smoking cessation counseling. Ask. Ask patients at every visit about tobacco product use. Assess. Assess the amount, frequency, and type of tobacco product used, prior attempts to stop, and current desire to quit. Advise. Advise in a clear, strong, and individualized way the importance of quitting. Assist. Assist by providing recommendations for both behavioral support and pharmacologic therapy. Arrange, connect. Arrange appropriate prescriptions, referrals, follow-up. An abbreviated approach, the AAC model, ask, advise, connect, is suggested when time constraints preclude a longer discussion. Pharmacological therapy to support tobacco use cessation includes varenicline, bupropion, and nicotine replacement. Similarly, smoking cessation programs and counseling, including cognitive behavioral therapy, are recommended as Class 1 interventions for PAD. Tobacco cessation coaches can provide additional support especially focused on reducing barriers to quitting and resisting the tendency to return to smoking. Other resources include 1-800-QUIT-NOW and web-based services like www.smokefree.gov. When counseling patients on smoking cessation, a discussion of the benefits should be provided. In addition to reducing the risk of a number of smoking-related cancers, smoking cessation reduces the risk of limb loss and amputation, heart attack, and stroke. In summary, smoking cessation represents one of the most critical steps in preventing progression of PAD, as well as associated cardiovascular morbidity and mortality. Smoking cessation should be emphasized early and often with an emphasis on providing the tools necessary for a successful and lasting discontinuation of tobacco use. Additional resources are listed here. Thank you all for your participation in this vodcast. We have covered numerous critical aspects of peripheral artery disease, and your contributions will have a significant impact on the PAD community. In closing, I'd like to remind everyone listening to encourage your patients to play an active role in their medical care by advocating for themselves and their family members. To get additional information, please visit AHA's PAD for Professionals website for more education. Thank you.